All right, I think we're getting close. So if the stragglers want to come on in and get seated, we have a stellar lineup. We're going to do Ultimate Aortic Cases 2. And we have Steve Yakubov is a co-moderator and Paul Mahoney, and we have an esteemed panel. And we will get started with Dr. Iyer is going to, I think you're first up, TAVR Lessons from the Past. So Vijay, if you're ready. Mike free.
Thank you. We saw the last session, really exciting stuff. A lot of talk about Basilica and unicorn and modified unicorn, all of this stuff. So I'm going to go back in the past. Hopefully there's some young people here who will learn from this. I'll get back every year or so. I kind of go back and look at all my mortalities. We've been doing this for 11 years, and it's going to go back and look at everything we screwed up on and what I can learn from it. Try to talk to my new fellows about it. So as I was looking through and saying what I'm going to present here, I kind of found this case from 2018. So here we are, 2018, and my disclosures. Okay, this is an 86-year-old woman, high-ish STS. Nothing extraordinary about everything else. This is sort of the patients we were doing at that time, high risk, severe valve stenosis. Needs a valve. Based upon the anatomy, we said she would be a 29 millimeter evolute. We wanted to do a evolute, and like we always did, before Hemal taught us how to do cusp overlap, we were doing some sort of modified cusp overlap. So we go ahead and plan an evolute valve. This is a 29 valve. You can see on the aortic root angiography that this is not the most generous sinus. It's reasonable, but nothing too generous. Coronary heights look okay. All of the measurements are here, nothing extraordinary. The SCJ is about 22 millimeters. Just keep that in mind. Just pay attention to this. Fairly reasonable deployment. Deployment is done. New operators at the table. One of my fellows who had just become an attending is operator number 2. Surgeon is operator number 1. A little bit of interaction with the valve frame at the top of the valve and a nose cone. They are trying to bring the wire back, but the primary operator pulls back a little bit too early. And you can see at the base of the valve frame interaction between the nose cone and the valve. Nose cone comes out, valve pops out. Okay? So patient goes into sort of impending cardiogenic shock, hypotensive. We're trying to deal with it, some rapid pacing, trying to minimize it while we make a decision on what next steps. The decision is made to go back and try to reimplant a 29 valve at that moment. So same valve, try to go a little bit deeper. Looks like we have adequate height. And that is the intention. So as they start to deploy, you can see ventricular contractility is already kind of not great. Flows are poor. Valve is sort of functioning with open 80%, but looks like coronary flow may be impaired when we deploy this valve. So make a quick decision to pull this out and go in with an Edwards valve. All of this is happening as the patient is continuing to deteriorate. Some thought about ECMO and putting the patient on ECPR, et cetera, but nothing is done immediately. The thought is get a quick valve in and let's make an assessment, try to stabilize the patient, go along.
Hey, Vijay, do you want to just back up for a minute? Yeah. Start with what should have been done differently on the nose cone management.
Yeah, I was going to come to it at the end and talk a little bit about communication and nose cone and wire management, all of that stuff. So if you don't mind, I'll come back to it at the end.
Okay.
But today, for anybody who does any core, a lot of you are doing it, you know that you pull the wire all the way back so that the nose cone is well away from the greater curvature with no interaction with the valve frame. And I think that's like the first thing you do before you even start to pull anything back. But that means exquisite communication between the first operator and the second operator, everybody talking to each other, telling each other, what are you doing? What am I doing with the wire? At what point is it okay to start bringing the delivery system back? Make sure there's no interaction. Today, that would be sort of one of those things you would never accept as something that you would, this should never ever happen, right? So here you are. So we go ahead, and this is not great. So trying to go in, and so they quickly deploy a 26 millimeter Edwards sapien valve. Remember, this is pre-DASI, pre-TAV and TAV planning, all of that stuff. They go based upon the original annulus size, which measured about 460 to 470 on the original. So at this point, obviously, the patient has deteriorated completely. It also looks like there is absolutely no coronary flow at all. left main, right coronary, everything. You've created, because of the higher implant of the core valve, you now have a tube graft, and the entire coronary system is shut down. Patient goes into rapid shock. Family has already decided before the procedure is done that they want no heroic measures, no ECMO, no sternotomy, nothing of that sort. So this patient obviously dies on the table. Lessons that we learned from this, right? I mean, so question is, what were the clinical challenges? The clinical challenge is, the first thing is, when the valve embolizes, what do you do next? And it'll happen. Even today, occasionally you'll have a valve embolize, either because, for whatever reason, you didn't predilate the valve adequately, you didn't, the valve rapid pacing was lost for a balloon expandable valve. It'll happen. I mean, 1 in 1,000 cases in a lab will happen. It happens to us. We've done about 5,000 TAVRs. It's probably happened to us 4 times so far. So it will happen, and you need to know how to deal with it, and deal with it effectively, because it's something that you will have to deal with. We also have learned that the best way to deal with these patients is not to call the surgeon and say, open the chest. That's not the best way to do it. You have to figure out how to deal with it, and there are very effective ways to deal with it. Then the next challenge is hemodynamic instability, hypertension, desaturation. What do you do first? Do you deploy the valve next, or do you stabilize the patient next and get them on ECMO or do something else? So have a strategy on what to do. Third, the quick decision to implant the new valve. So you have to be a little bit thoughtful about what the new valve is going to be. You have to think through, and this is where the thought process now of knowing, since we now talk a lot about lifetime management, we're already thinking about that second valve. So hopefully, when you're deploying the first valve, you already thought about what that second valve strategy is 10 years from now, or in a case like this, what the second valve strategy is 30 seconds from now. And again, remember, this is pre-TAV and TAVR. That's a lot of the decision-making, what of our understanding, which has come subsequently from a lot of bench testing that Janar and others have done. We were obviously inadequately prepared for this situation. So obviously, we talked about evaluate the appropriate depth. We walked through all of that. So let me talk a little bit about key learning. So I think in TAV and TAV and in any kind of embolized situation, you have to sort of make a quick decision on what to do. What would we do today? Knowing what the STJ dimensions were, the first thing I would do is to hemodynamically stabilize the patient, probably put them on ECMO, if they are hemodynamically unstable. If they are stable, you have the time to kind of make a decision, go forward. The first thing with a long frame valve, when it's come up, I snare the valve and pull it back. I think that's the first thing you need to do. Intuitively, it feels weird. Like, I still remember thinking about this 5 years ago and said, what? You said what? Because Horst said to me when he looked at this valve, why didn't you just snare it? What came to me at that moment to snare it? But that's the first thing you got to do. You got to snare it. And the way I like to snare it is I actually go in from the wrist and from the leg, snare both ends and pull up, and then make sure your wire position is maintained, and then you go in and put your second valve, whatever you choose to do for the second valve, depending upon the primary anatomy. I will make the statement, and I know people may not like this, majority of valve embolizations occur today because of operator error. It is operator error in not adequate planning, not adequately understanding the technique, and more importantly, oftentimes what I see is inadequate communication between the first and the second operator. When the first operator is doing something completely different from what the second operator's intentions are. So the two people really need to be in sync. One person needs to be in charge, communicating effectively. So I will stop with that and take any questions or comments.
Vijay, thanks for showing. That's a great case. Back in the bad old days, the original core valve, this was more than a theoretical concern. So we would try to get it above the STJ, snare it, hold it in place, and then go with the second valve and use the second valve to anchor the first valve above the STJ and try to avoid that, that long sort of tube that would sequester both sinuses. So that's a good case. And the other is, a lot of these are, they're not big errors. They're just a bunch of small errors that add up in communication and talk and pulling a wire, pulling a nose cone too fast, and making sure all the team is in sync. So if you had this today, how would you have handled this differently? Let's say this happened tomorrow.
We spend a lot of time now with our trainees and even our junior attendings and talking about wire management and how to pull back the wire back. Make sure your nose cone is completely away from the frame. Watch the nose cone coming out. Stop if you feel there's any interaction, and then reintroduce the wire into the ventricle. I think that's like fundamental to how we bring the core valves out. The second part is, once the valve embolizes, and if it does embolize, I think the first thing is make sure you maintain wide access at all times. Pay attention to the hemodynamics first. Act and stabilize hemodynamics first. Second, if it's a self-expanding valve, snare it. And oftentimes that means you may need to get additional access to snare and pull it back. Take the time, do it, pull it back. I actually prefer to pull it way up because oftentimes when the second valve comes in, you get interaction between the two valves and it's going to move a little bit, even if you've snared it. So I like to snare it, pull it back as much as I can, then go back into the second valve. Deploy a second valve and then figure out what you're going to do about the first valve. If it's high up, take a balloon, drag it back as much as you can. Make sure not to tear the aorta because that's a major concern you could with the long frame valves. If it's a short frame valve, it's a balloon expandable valve, you bring it back to the arch or even into the descending aorta if you can and deploy it at a spot where there's no side branches. Take a picture. Make sure that the side branches coming out there are adequately filling. And if you have any concerns about it, reposition that. So that's currently what I would do. And again, if the patient was salvageable, getting them on ECMO quickly allows you to spend the time to do the right thing with the valve and not have to worry about two things at the same time. It takes, in today's day and age, it takes less than 5 minutes to get somebody on ECMO. You can get that patient well stabilized, and then you can make your decision.
So Bruce, you've done a lot of self-expanding. Have you had one that you couldn't snare? And if you did, did you have any other tips or tricks to address that?
I mean, I think it's everything that was discussed. The one thing we teach new operators with this platform is if you're not 100% sure if you're detached, your first move should never, ever, ever be pull, and it should always be push. So we just say if you have good wire position, just push in, and A, that might mitigate the problem and free you up and release you anyway, and B, you'll never pull a valve out, but you'll at least potentially see if you're bending on the crowns, then you know that you're still attached. Because sometimes people just aren't sure if they're interacting. And I think the other key thing which you mentioned is just going into the case all of your CT measurements. So we always have in the back of our head, what are our sinuses? If we have an embolization, what's going to be our options? If it's going to be a valve-in-valve, which platform we're going to use? Can we leave it where it is if the sinuses are generous, or do we have to snare it up? If it's a balloon expandable, we've had some luck in some cases with actually just putting the balloon in and then inflating the balloon and then using the balloon to pull it up. Is obviously snaring is your best option. The thing with snaring is just never let go. We always teach our new operators, obviously, when you bring in the next prosthesis, maintain some tension on the snare, otherwise you're just going to push it right back down. And I just think finally you need some luck, right? You need to have an aorta that's like kind of the right size to pull it up, because if you pull it up and the aorta is big, next thing you know, it's just kind of bouncing around and jostling around, and you're not going to be comfortable leaving it, versus if it lodges in and locks in on the outflow and it's just the right size and it stays put, then you're in good shape.
So some of the concerns that people have with snaring is bringing it up, and can you cause aortic dissection? How do you secure it? Hemal, do you have any comments on how to figure out how much pulling is too much, and how do you secure the valve if it's got that little movement occurring with it?
Yeah, thanks, Steve. It is kind of a challenging assessment, but I think Vijay was spot on, just understanding, and Bruce mentioned as well, understanding the CT, understanding what your sending aortic measurements are, understanding the angulation. And then, we had a case that, was very similar to not this one, but it kind of popped at the end. And this was something where the ascending aorta was quite narrowed, and our ability of snaring one of the tabs was going to be extremely limited. So in those particular cases, we went for a more invasive form of management. But I think understanding the anatomy up front is key. And then the other thing I'll add to being sure that you're off the tabs and not pulling, change the gantry angle. Just try to do a thorough assessment. I think that's even more relevant with Navitor.
Absolutely right.
Because, you've got 3 attachments for that valve, and you need to spin the gantry in order to see all 3.
The one other thing is you just mentioned about the other maneuvers. They did, if you look back at they did pull wire.
Yep.
But the nose cone didn't centralize. So they did the right initial move. And I think the issue was, if that doesn't work, then you've got to do something else. And it's usually a combination of push with a little bit of rotation, either.
Right, what they didn't pay attention to was there was a little bit of interaction in the top of the valve as well, which is why the nose cone didn't move, because the nose cone was stuck in an angle, and they didn't really spend the time. All they needed to do was to kind of maybe do the little maneuver so that the top of the valve went to the greater curvature, so the nose cone would move to the center.
So Alan, what's the role of ECMO in your institution in this, when this happens? And keep in mind that ECMO will keep the patient alive, but the anterior wall is going to keep infarcting as long as you don't have any flow down the coronary.
I think we upfront, probably like other institutions, will decide what is our bailout strategy, and we identify it right up front. ECMO in our institution, probably like everybody else's, is easy to do. The pumps are now easily available. Stabilize the patient and then take it from there. You need a stable patient in order to make sure you can then do other interventions.
Vijay, that was a great case. Thanks for starting us off. Thank you. Next is Summer Abbas. Summer, talking about landing zone optimization. Do you have
Thank you so much. Thank you for having me. Thank you both for the invite. I'll be talking about landing zone optimization for TAVR and lifetime management. So we'll discuss a case in the next 8 minutes about lifetime management for TAVI. So these are my disclosures. So TAVR success depends on the valve deployment. Obviously, we would love to have one valve only, and that's not reality. But I think your initial valve and the choice that you do, it's gonna make, you're gonna achieve maybe the best outcome you can. So if you have to do it again, you'll do it successfully. So lifetime management, meaning that anticipation for a future valve, for PCI, coronary access, obviously conduction abnormalities, all these anatomies for future intervention. And regardless what valve you choose, whether a balloon expanded valve or a self-expanded valve, I will say we gotta think about all concept of depth of implantation, PVL, conduction abnormality, and one of the most important things also the commercial alignments for future coronary access. We have a lot of modalities. I will say maybe CT is a gold standard. However, we are more advanced now. We're talking about 3D construction, reconstruction. We have the fusion images, and now we have also the simulation tools that will allow us to pre-planning what's the valve that we're gonna use, and in the future, what can we do if we need another intervention. So let's start with this case. And this is a case that I've done about 4 weeks ago, and this is how we practice in our institution. 64 years old male, had a severe symptomatic aortic stenosis with moderate AI. His EF called about 25%. Obviously, the ventricle is still alive. He was able to generate a 45 millimeters mercury, and he has hypertension and hyperlipidemia. This is his echo. I will say, in my institution, this patient will go for surgery. So I recommended an open heart for this guy. A surgeon believed that this is not a 20% ejection fraction. This is less than that. And he has his BMI was about 38. So the decision was like, he's a high risk for surgery. Patient declined surgery and wanted TAVR. I practice, as Mark knows, I practice in an area where there's 70 TAVR institutions. So if I don't do it, somebody else is gonna do it. So we offer this patient TAVR. Now, again, if we're gonna do TAVR on this patient, we're gonna plan this so well that either this is the valve that's not gonna come back, or if it's gonna come back, we're gonna be ready for it. And that's how we plan. So pre-planning is the most important things. Now, if you look at the CAT scan, he has no other valve disease. His ventricle is dilated, doesn't have coronary artery disease. He does not have an aneurysm, and it looks like a tri-leaflet valve. So for me, this is not a very complicated, no coronary artery disease, no ascending aneurysm, tri-leaflet, not too much calcium in the LVOT. So I think it's a reasonable case to do TAVR, other than the age, as I said, again, we offer him surgery first. So if you look at the measurement, obviously CT is the gold standard, and we all know here, we've spent a lot of times in CT first. If you look at the measurement, you measure about, like, I will say, I can't see from here, but it's about either 26 S3 or a 29. His SOV are large, very big. It's a tri-leaflet valve. We can seal in the top if we choose what valve we need, whether if we want to do evolute or S3. And the LVOT kind of widen a little bit, but is not too much calcium, little bit of calcification in the STJ. Coronary heights are very good. So I think this is a very, I will say, straightforward TAVR case. Now, every case I do, in this case, 64 years old, no coronary artery disease, I think, if I can get a bigger valve, great hemodynamic, I will choose the bigger valve that I can. So I choose a 29. I think I'm going to have a good result with this valve. I'm going to plan it first and know in the future and this is what we do in every case for us. So as you see, we put a 29 valve, and now if you see the line, the horizontal, if we deploy in the future an S3, you can see that I have no problem with coronary access, whether the left main or the RCA. So I'm very comfortable. I'm going to deploy that valve in a optimal way. And if I need in the future to come back, I can come back and put a valve with no issues. This is obviously the master of cusp overlap is here. And I think this is one of the really a great way you taught us all. And I'm really appreciate for that. So this is how I practice. I'm a minimally invasive, obviously, left radial, pigtail in the non-coronary cusp. I pace over the wire. This is a Safari wire. We go for the cusp, first of all, in LAO. We assure the hat in the outer curve, and basically that will assure the commercial alignments. We will go only on the non-cusp here, and I'm at 3 to 5 millimeters. That's my sweet spot. And then we can take pictures at 80 degrees and then 80%. And finally, we go on pace when we do the final deployment. And I think, slow deployment, achieve about 3 to 5 millimeters, knowing also that if I can put a valve in the future, I have no problem accessing the coronaries. These are, we should know, the coronary risk plane, which is the lowest line from the ostium of the coronaries. And also, we should do also the HAV risk plane, or what we call it, the neoskirt. So in every valve I deploy, I basically am familiar with what is the coronary risk plane for this case and what's the neoskirt risk of obstruction. Those are numbers important. And because if the coronary risk plane is higher than the THF or the neoskirt risk, then there is no problem with coronary access. I know that I can come in the future and put another valve. I plan this for every single case. This is, so you know, a comparison for the risk plane for TAVR. And as you see, you gotta plan it correctly, and you gotta look at the valve that you're gonna use, because it's not necessarily in all the time that the neoskirts, like I give you, for example, like if you look the neoskirt of the 20 millimeters valve, it's smaller than the 16 for the 23, but it's not the case in the 29. So you gotta plan this, and you gotta know what valve I'm gonna put and what's the height of the neoskirt. The neoskirt, when you are gonna pin those leaflets, so you plan for the future the best deployment. And so pre-procedures planning is important. And the reason I'm saying that, because those younger patients that they're gonna come back and we're gonna put valve in valve. So we have tool, we can look into the valve, and what not, we're gonna put the other valve in our patients. You can see if we did like a knot 4 or 5 or 6, and we do the measurement for the VTC, the VTA, and also the VSTJ, which is very important. It could be the most important. Any of those numbers less than 4, we will pause and we will see where we're gonna deploy that valve, and is there anything else like a leaflet modification we're gonna do or not. So we know this ahead of time. And you can see also here that if we put in S3 in a volute, the S3 will shortening from the bottom, not from the top. So if I know before that I am going to put it at node 5, I know exactly all what I need to put the top of the S3 in the node 5, and this is going to shorten from the bottom, and I have no problem access the coronaries. I know that ahead of time. In general, anywhere between 4 to 5, we are going to be okay, and we should know this before. And this is an example for the valve sizing strategies that if you want to do whether Navitor or a Evolut or S3, it's all available, and we can all see it. So going back finally to our patients, as I said, we use a cusp overlap, commercial alignment. We go on pacing, deployment at 3 to 5 millimeters, And I know where, if I'm going to put an S3 in the future, I can put a 26 valve right at the bottom, and I have no problem with coronary access for the future. So in summary, landing zone optimization, cusp overlap technique, and commercial alignment are crucial. They're very important for future. Precise the size of the valve, the depth control, and also longevity and coronary access are extremely important for a future valve-in-valve. And happy to take any questions. Thank you.
That was a really tough case. You can make a case for that being aortic insufficiency rather than aortic stenosis. Do you modify your plan based on that?
Yes, I do. Yeah. I mean, this is, I will go with the same depth. The only difference, I think, with the AI, we've done a lot of AIs, obviously off-label. I will say that. I don't think it's going to make it's just making it a little tougher, right? Because I think this valve is, I think, fused, and there's a little calcium would help me. But the pure AI, obviously, I try to pace more. In this case, I'm going to seal in the top, so I know that it's going to be, honestly, okay. Yeah.
Summer, I got a question for you. So it was a great case. So in these cases where you have like a good volume of AI and you've got this left coronary cusp in a younger patient, do you ever give consideration to just obliterating it? I mean, it's usually very easy in these native leaflets to do that. So I was just wondering what your thoughts are on that.
It didn't come to my mind, but I think it's a good point. I don't think, actually, I thought about it this way, but I was hoping, again, there is a little amount of, in this particular case, I thought I'm going to be okay, sealed in the top. I think, if you notice, the deployment was very steady, but I also pace at like 160 from the top, and I end up in these cases where I know that there's a lot of AI, I honestly go 160, 180 all the way, very slow. So I am preparing for that, but that's a good point. I didn't think about that.
I think you illustrate a great point of your first procedure will dictate what your next procedures will be set up. And I think that's the big dogma that has to be implemented in all of our training programs. When we do valve or TAVR and TAVR, I think it's a theoretical plan to say we're going to place this at node 4 or 4.5, and you potentially move this or inflow to inflow or outflow to outflow, and you plan that piece. But the moment that you start pacing and you begin to inflate, I think when you do a balloon expandable valve, it doesn't always say that the top is where the valve ends.
Excellent.
So I think we do have to be a little bit careful on how we make those recommendations, because it's very unpredictable. And if you pull too hard, then you're coming up with the prosthetic that you had implanted.
I agree, and I have not done. Majority of 60 or 70 of our volume is a self-expanded valve. And quite honestly, I feel like those solid hemodynamics valve, and we're not seeing them back as much. So I did not do a lot of valve-in-valve, but I completely agree. I think there is instability and foreshortening from the bottom, not all the time. So in those cases, I'll put a catheters and a wire, honestly, even if I know where I'm going to be. I just don't want to take a chance. So I usually put a guide and a wire, and then I deploy it. But 100%, yep.
I think with those two, put the outflow, if you're doing short and tall, put the outflow where you want it to land, and don't start figuring out the foreshortening because it's unpredictable. But usually the outflow will stay kind of where you start.
So that's what we're saying is like, that's what we're hoping. But sometimes I think when you pace, it will move. Yeah, that's the issue. Yeah.
They tend to nest.
Yes.
You have to be prepared for that, especially the balloon expandable. Instead of either another balloon expandable or a self-expanding, they're going to tend to nest. So it's entirely different control than you have in a native or even a surgical valve. And you have to be prepared to go inflow to inflow and understand that the first point of contact, it's usually going to stop moving at that point.
Right.
So.
Right. And those are the cases that, like you're going to see. I mean, I'm sure everybody, like you have a 64 years old probably in our institution should go to surgery, but this is not the case in the real life. We all have done younger patient, and first valve that you choose to put those patients, I think, is the most important, and where deploy it. You still deploy at 0 or you change your practice?
No, it's idiosyncratic, and honestly, I've never supported deploying at 0. If you will just take that tangent. Honestly, the beauty of that technique is understanding where your true position is going to be. You just demonstrated that magnificently on that case. You basically picked your shot, you called your landing, and you landed it right there. That is really what this view, what this technique gives you. And the top-down deployment technique, understanding where to start with the marker band in the view, that is really going to give you your true positioning of this particular prosthesis. And I would say any prosthesis.
Just one other comment, at the risk of sounding like a pariah about valve planning. I think we do have to plan for future interventions, and we're all trying to do that. But to your comment, Paul, previously of what we're doing now versus what we're going to be doing 3 and 5 years from now, we have no idea. I think sometimes when I talk to some other operators in their institution and they're all focused on lifetime management and what's our next procedure, I also think you can't lose sight of like, what's the best procedure we have to offer this patient tomorrow? And with a guy with an EF of 10 to 15%, I'm not sure that I have to worry about what I'm going to do 15 years from now for that patient. And I think sometimes people get so caught up in the gaming out the future that they lose sight of doing the best procedure at the least risk that we have for that patient we can offer them today.
That's, I'm sorry, I'm just saying, I didn't want to say it, but that's exactly when we talk about it in our heart team discussion. This EF is like 10 to 15%. I'm not sure if this guy is going to live 15 years old. So in my opinion in this, and I might be biased a little bit, I gave him a 29 self-expanded valve, end up with mean gradient of like maybe 2 or 3. I think this is the best valve that this guy will have. And I'm a little biased about that, but this is the best valve that this guy have and might not come back.
Yeah, we'll sometimes see what, we talk about this, but sometimes you try to game it out and you realize that the next valve is going to be a horror show, no matter what you do. And you got to take care of the patient in front of you today and hope that the technology will catch up with you. As long as you acknowledge it, talk to the patient about it and say, hey, the next procedure is going to be challenging, but we think this is going to give you the best combination of hemodynamics and safety. And that's going to be a technological challenge, which hopefully we'll have enough time to solve during that patient's lifetime.
I would just add one more comment to that. So, it is kind of like, how long are we on the hook for with these patients, to Bruce's point? And so I would say that, 30 days, 1 year, absolutely. 5 years, for sure. Beyond that, that's tough. What other medical provider with an intervention is really going to hold themselves, or the community hold that person to that hook for that extended period of time? And I think that we've taken a lot of the clinical science and a lot of the responsibility that we've done in short-term, intermediate-term outcomes, and now attach that to more longitudinal assessments that I think are completely off in the future and completely random chance.
Yeah, that's a great point, Hemal. And some of you on this panel have to worry about it a little longer than some of the others of us. So good luck. We'll go to our thank you very much.
Thank you so much for having me. I really appreciate it. Thank you.
Dr. Tarantini, who is going to come and talk to us about TAV and TAV success or failure. A lot of great comments during the last session. We'll look forward to this talk. There you go. And do you have a microphone? There you go.
Hi, good morning, everyone. So it's a pleasure for me to be here. So as you can see by the title, Ultimate Aortic Case, TAVR and TAV Success or Failure, let's walk this fine line together. This is the first case, 84 years old man, AFib, treated in DOAC. The first intervention was a surgical replacement with a stentless valve 2002. 17 years later, this patient underwent valve-in-valve with Evolut Pro 29 that was appropriately sized at that time. It was not an undersized or oversized. It was appropriately sized, trust me. In 2025, the patient was admitted again because of an acute heart failure, very low ejection fraction, structural valve degeneration. So the reason of biprosthesis failure was severe regurgitation, not due to endocarditis, thrombosis, or other things, but structural valve degeneration and no PVL. So what we have to do next? It's, we cannot discuss about surgery because at this age, nobody will go for a third intervention as surgery, second intervention as a surgery. And actually the decision was to go with a THV and THV. So just to be as simple as possible, but not too simplistic, we need to answer to 3 points. The first one is the THV type. What is going to be the second valve? So we are discussing, so far about the first valve. We can discuss a lot, 5 years, 7 years, etc. But what about the second valve? And secondly, how to size and position the second valve. So related to the first point, it's pretty much easy because when you start with a tall frame valve, unless you have a huge ascending aorta, the second valve is almost invariably a short frame valve. And ideally, you need to stay below the risk plane of this patient. So I try to explain a little bit better with this scheme, with this figure. When you go short in tall and you stay low, and you can stay low, because sometimes you don't have the risk to, sometimes you have the risk to threat the coronary artery anyway, but it's better to stay low when it's possible. You have 2 layers in front of the coronary. On the right-hand side of the panel, if you go tall in tall, you have 4 layers in front of the coronary. And even though you get rid of the leaflets, whatever is the, the device, electric, mechanical, etc., you have a misalignment of the mesh of the frame. And for instance, with the core valve, not the FX plus, with the previous core valve, you cannot cannulate the coronary artery anyway. So when you do the basilica, the only things that you can guarantee is to have a coronary flow, but not a coronary cannulation in the vast majority of cases because the closed cell design of the valve. So related to the second point, sizing. This is one of the most important parts, and also difficult part of the THV in THV. This is the CT scan of the patient, and here you can see the cartoon that tries to summarize the measurements. So the inflow was 23, even though the core valve 29 should be 29, not 23. So the valve means that it's constrained or underexpanded. At the level of the waist is 23 here, but 23, when we measure 23 by CT scan, we go from frame to frame. But we need to take away at least 1 millimeter, 1.5 millimeters off because of the thickening of the leaflets that are degenerated. So it's less than 23. And here you can see the VTC and VTA. The only one that creates some concern is the VTA at the level of the right. It is 2 millimeters. When we compare the valve implanted in a patient with the valve on the bench, as you can see, the inflow should be 29. And the waist is 23 for the 29, is 22 for 26, is 24 for 35. It's really one of a kind type of, the design of this valve. And so we need to consider these two things. We cannot trust just on CT scan. This is one of the, major mistakes that we can do when we size the valve. I'll show you why. This is another important point to consider, the commissure alignment. In this case, it is clear that the coronary artery one is here, the other one is there, and these in red are the commissures of the valve. So in this regard, we don't have any problem because it means that the commissure stay not in front of the coronary. Let's move forward. Third point to consider when you size a valve, on top of the fact that you can use the app, but I think it's important to be deductive and to understand exactly all the steps before deciding which is the size and the position of the valve. So the question is 23 or 26. We can vote in the room. Probably we might have half of the room that says 23, the other half is 26, or 1/3 or 2/3. But actually, for sure, there's going to be not homogeneous. And the point is, the mechanism is important. Why? Because if we have a wrist stenosis, we have seen many cases in the previous session, the general thinking is that the risk of coronary occlusion is very high. So we need to go for leaflet modification, we need to go, for other type of procedure, chimney, snorkeling, and so many things. Because, why is that? Because the second valve is to be placed at this level because we need to pin open completely or not completely, but enough completely the leaflets, because we need to have an effective orifice area that is acceptable. So the risk of coronary artery is not low. Regurgitation, in case of regurgitation, you don't have this problem because you can put the valve down here, also just below sometimes, many times below the coronary artery. But the point is that when you don't have calcification of the leaflets, the point is it's very difficult to anchor the valve if you go with an oversizing of 5%, 10%. So you need to think like a pure aortic regurgitation in many cases. So it's important to upsize. It's not an upsize, it's an appropriate upsize. Because the way we anchor the valve is totally different. So having said that, go back to the case. On the contrary of this kind of reasoning, this is part of the registry, the TAVR registry, that's in which we enroll 150 patients, is going to be presented at TCT. This is a very important case because the operator, because of the CT scan, even though second opinion of the experts tell him to implant a 26 in a low position, he decided to go with a 23. 23, but this was the result of this 23. Look at the valve, there was a pop down of the valve, likewise, the aortic regurgitation, the typical case of aortic regurgitation. So what they have to do, in this case, this is a failure, the case of failure, and they had to go with a 26 valve implanted, this is just to simplify, below the coronary. So below the wrist plane, just to have 2 layers in front of the coronary, and with a 26 implanted not at the level of the waist, because we are below the waist, and the waist is 23, the inflow is 29. In between is between 23 and 26, so it's not 23. This is the result, the gradient is 4, and the coronary cannulation was possible. Let's move on very briefly to the second case. It is a flip, the side coin, the flip side coin compared to the previous case, 82 years old. 2018, this valve was bicuspid. The patient was treated again with the Evolut 29. I decided to go with these 2 cases because it represents 2 complementary cases that are very important to understand the sizing and the positioning in case of failure of the Evolut Pro. 2025 admitted because of heart failure, the ejection fraction was 56, structural valve degeneration. In this case, was not aortic regurgitation. It's interesting because probably one of the most interesting findings of this registry, if asked to all of you, how much is the rate of regurgitation compared to stenosis? It's very difficult because we don't have data, but I can guarantee to you it's totally different among all the types of THV. But it's differently from surgery. Vast majority of cases, regurgitation, this is a good thing because we can put the valve a little bit lower, we can reduce the risk of coronary occlusion. Anyway, in this case, 62 was the gradient, DVI 0.18. We don't need to repeat that, just to evaluate together again the CT-based sizing. 25 in this case, less constrained compared to the previous valve. 22 is at this level of the waist. Commissural alignment was not perfect, but this is a bicuspid valve, and the RAFE is forgiving because while you have an increase in pacemaker rate because you push the valve towards the membranous septum, actually at this point you have a lot of room between the frame and the wall of the aorta, so the coronary flow is there. You don't have any problem in terms of coronary occlusion. This is the matrix, you know everything already. So the same concept, 23 or 26. Here the site of implantation has to be high because we have a significant stenosis, so we cannot stay too low. We need to stay at the level of the waist. The gradient is 50. One thing that I forgot with the previous case, I would recommend, you will see your experience also, the pre-dilatation is extremely important. Based on the number of cases that we have done, I would recommend in 100% of the cases. Also in case of aortic regurgitation, especially if the valve is constrained, because when you go with the 2-layer, with the second layer, expansion of the two valves is difficult because they don't slide one with the other. It's much more complicated. So you need to pre-dilate. You might decide if you want to go with a 23 or more, because when you have, for instance, the portico 27, you need to go at least with a 25, because otherwise the balloon slip inside. In this case, 23 is enough because the waist is 23, so the balloon is anchored. So the balloon size depends on the first THV that you put in these patients. We implanted a Sabian 23 in this case in a very high position at the level of the commissure, because the point is to tilt up the leaflets completely. And this is the result, 18 millimeter of mercury, that we can discuss, is it acceptable? Many times in the meeting they say, when you stay below 20, it is acceptable, you don't have to risk anything. This is not like that. because we need to stick to some sizing charts that has to be produced exactly like the native valve to understand what is acceptable. Why is that? Because when we have 18 millimeter of mercury, we might have a pinwheeling also of the leaflets because the valve is not expanded. And in this case, we went many times actually with the 23, again, 3 cc more, long inflation, double tap. Double tap means post-dilatation, deflation, and again another post-dilatation just to optimize without changing anything, without changing the size of the balloon, because it's important sometimes to reduce the gradient. This is the result, 1 millimeter more, but the point is 2 millimeter more. So we cannot accept 18. So why I presented these two cases? First of all, to demonstrate the different sizes with the same size of the valve, the same type of valve. Second things, we don't need just to go for pre-procedural planning, that is the focus of the vast majority of the meeting. We need to go for the assessment and the optimization of the procedure, pretty much like we do with the coronary artery, 20 years later. So the point is the assessment is invasive gradient in all cases, because you might have a great dissociation compared to the echo. Sometimes you have at the echo 30, you have 5 millimeter by invasive gradients, because the echo doesn't take into account the pressure recovery and so many other specificity of the valve. So invasive gradient is important. And also the double view to evaluate if the valve is constrained to optimize the result, not only by minimal gradient, also the qualitative view, the cusp overlap, and tricusp view. This is a success. This is the CT scan. As you can see, it's very round, even though the valve was bicuspid. There is no pinwheeling. And actually, we are pretty much okay with this kind of results. This is just to create some expectation for October. I think we will present this registry. It's the largest registry worldwide so far, 150 patients. There is core lab for CT, echo, case review, adjudication board. And in all cases, we underwent for invasive evaluation and selective coronary cannulation of both arteries, because we need to have this information on top of the coronary perfusion. So in summary, TAV in TAV is not just a repeat procedure at all. It required forward thinking from the very first implant. We need to be familiar with this new concept. Neo-skirt, we have seen the previous case with the neo-skirt, leaflets overhanging, commissural alignment, THV expansion, because for instance, if you put a 26 valve in a 23 core valve, you have an expansion of 2 millimeters. So we need to know all these aspects. And that because we need to anticipate the risk of coronary access, RETAVI option, gradient, and long-term performance. CT-based planning is important, but cannot be, the only factor that you consider. You need to consider also the valve metric on the bench, and these two things are really key for correct sizing. That is related also to the mechanism of failure, because it depends where we want to put the valve. A short frame THV with the wrist plane below the coronary, there was an interesting discussion before about the durability. The durability is the factor to consider, for instance, for surgeons, because actually, the valve has to be durable 20, 25 years, etc. But when we have an alternative, it is the THV, durability is not enough. We need to be also, to put a valve that is also revalvable. So the revalvability is as much important as the durability of the first valve. To keep future option open, the short frame keep all the future option open when you stay below the coronary. If you stay above the coronary, it's exactly the same of the core valve, the navitor, and all the other valve. There is no difference. It depends where you put the valve. In a tall frame, the limits is that you need to have a very wide aorta, because in case of reintervention, it's very difficult to go with a tall in tall for the risk of coronary and the risk of, let's say, create this neosinuses structure that we don't know a long-term follow-up what happened in terms of stroke or thrombosis and so forth. Thank you for
That was an unbelievable explanation. So, and the cases were awesome. I do have to stay on time on this meeting a little bit more. So, great points, great cases. Thank you so much. Yeah. Okay.
I can go. Thank you.
Yeah.
Thank you.
Yeah. Thank you. Okay, so next is going to be Dhaval. Thank you for sharing your case on malposition management.
Right. Thank you, Paul and CVI, as the moderators, for the invitation to present this case. I think we had a lot of good discussion during the first case that Vijay presented, which should be applicable here. These are my disclosures. So this is a 72-year female with severe aortic stenosis, dyspnea and exertion in NYHA class 3. Not much in terms of the cardiovascular history, just hypertension, hyperlipidemia, and obesity. What's not shown on this slide is the non-cardiovascular issues with she had osteoarthritis and mobility issues. Went through the usual discussion at the valve team meeting about SAVR versus TAVR. This was a CT scan. So annular area about 330. Good coronary heights, right and left, both around 12 and 13. Sinus height about 15. SOEs are on the smaller side, about 26, 27, and 25. And then the STJ diameter on average about 25. So again, the discussion was ideally surgical AVR with aortic root enlargement.
Why is that ideal?
I'd say she's 72, low risk for surgery, except for her orthopedic issues and mobility issues, which is why I think the ultimate decision was to pursue TAVR. But I think with the small annulus and a low-risk patient who's likely has at least expected to require a second AVR down the road, that was our team's.
But you thought surgery was ideal because of the redo TAVR issues 12 years from now?
Yes.
Okay.
Alan, what do you guys do?
Yeah, I mean, I think it's a holistic assessment that Dhaval is kind of pointing out here. I don't think that there's a one-size-fits-all strategy based on age and anatomy. It's all idiosyncratic. And then the patient preference definitely matters, right? And so you're having a discussion, you're going to participate in shared decision-making, you're giving them the acute term benefits of either strategy and then the long-term ramifications. And then, honestly, you just work it out with the patient and you go with that. And that's what we do kind of in a heart team setting, surgeon, interventionalist, patient.
You know, we actually like information. And like you did, we do the CT reconstructions. We actually are using much more 3D modeling as we approach this lower risk patients or these patients who will likely, or who we think will outlive a valve, because I think we're very bad at predicting that. And then once we have the information of are we going to be successful in doing a TAVR procedure if we go through TAVR, or if we can't do that, then we will consider the surgical option. But I think the age piece by itself should not be the reason for SAVR. I do think that this anatomy is more tricky because of the size of the patient, of the size of the prosthetic and the potential redo TAVR afterwards.
Yeah, completely agree. Are you mostly using DASI or like doing it locally? Okay.
Markus, you're an imager. Is he still up? When you look at this CT, do you describe this as a high risk or a low risk for TAVR?
I mean, again, I'd be worried about the ppm. It doesn't look particularly high risk from a coronary obstruction standpoint, but then again, the lifetime thing, next valve would be the concern, especially with how narrow, excuse me, the STJ is.
Markus, what would you tell Jonathan to do in this case? Would you tell him to send this to surgery, or would you tell him that this is a better TAVR case?
It depends on which surgeon is on the conference that day. I mean, we're very pro, if we think the patient's going to be around for a long time, and Jonathan can chime in if he wants, if he's in the crowd, but we're very pro letting the surgeons have first hands-on if we think the person's going to be around a while and have more options. And I think you were already talking about you're planning on doing an aortic root enlargement if they have good success with that. I think that's very reasonable. But we're it's very fluid.
So I think this is a good TAVR candidate. That's why I'm trying to be a little.
Yeah, no, I think all great points, and we had the same discussion at our valve team meeting. Eventually, like as Hemal pointed out, we have to take into consideration the patient preferences and shared decision making, and the decision was to, like, her preference was to go with TAVR. That's what we went forward with, and this is we decided to go with the 26 millimeter Evolute FX Plus, given the small annulus. So usual cusp overlap, the depth doesn't look bad, about 3 millimeters on the non, and maybe a little bit deeper on the left. And then went ahead, deployed the valve. As you can see, it took a little bit of maneuvering to get that second tab off, as we discussed during the first case that Vijay presented. Just kind of slide forward pressure to make sure that it's still attached or not. And it was still attached, as you can see the it bending outwards, and then finally it released. So we're happy at this point, but that lasted very short. So as you can see here.
I was just going to say something about that nose cone. So I think Vijay showed the case earlier about the nose cone. When people say to pull back the wire, you can pull the wire right to the very tip of the nose cone. It'll lay against the septum. If you're a person who believes in pacing on the wire, it'll still pace. You just need a little bit out there. So when this nose cone was pulled back, I didn't see anything where it was a real nose cone pullback. And I think that's where you get hung up a little. Hemal, is that, what are your comments?
Yeah, I agree with that, Steve. And I think that we have to be cognizant of the wire that we're using as well, right? So, I mean, you've got a firm body, rigid wire. Yes, it's pre-shaped, but that's going to be pulled back to the nose cone. That's going to alter where the nose cone lies. I mean, my personal preference is to use double curve Lundquist in virtually every case I do. That has a 15 centimeter transition at the tip, which, you know, kind of is like nice and floppy, lets the nose cone kind of do its thing. So I think you have to be cognizant of that. You can pull the wire out of the delivery system without an issue and then re-advance or gently navigate the nose cone out to the descending aorta to straighten things out. I mean, we do that, you know, fairly routinely. Bruce, what do you do?
I mean, everything that you've said, but to your point, I mean, you can pull the wire out entirely and just go back in with like a softer wire, change wires. Sometimes you don't always know if it's going to be softer, stiffer, what it's going to do. You just need to change the dynamics. Always a little bit of push, catheter rotation. If you take time, you can.
Yeah, no, all great points. And I think, I mean, we routinely go through the same steps, like pulling the wire, making sure the nose cone is off. I think in this case, unlike the first case that was discussed, the nose cone didn't catch on the edge of the valve, but rather it interacted with the tab, and that's how it was embolized up. As unfortunately we didn't save it and saved it, the later part of it coming out, but the interaction of the nose cone was more with the upper, the tab of the valve.
So this is a good picture. So here the valve is embolized above the STJ, so the coronaries are perfused, and you have some time.
Yes, absolutely.
I'd be interested to hear the panel at this point, what valve they would they do surgery? Would they pursue surgery or another valve, and if so, which valve?
Well, I'll start. How's that? You know, I think
Awesome.
in this case, I would snare the valve, because when you go through it, it's going to want to dive lower. And even though you are above the coronaries, you probably should be a little higher than that. So holding onto the valve would be fine. I think you could use anything you want. You could go right back with an Evolute, because you're not going to occlude the coronaries. You probably deploy a little differently. It'll probably stay in place a little bit more because you've got the anchor, and you're probably not going to pull it up that high. You can use a Sapien. You could do whatever you feel like at this point in time, but I would hold on to the valve. I would snare it and hold on.
So with a Sapien, though, how would you stop this valve from falling back down to the sinus? I like the tall frame valve because it anchors, the first valve is anchored with the second valve. It kind of pins it.
I don't think you're going to have much worries about that, because the top of the frame looks like it's the size of the ascending aorta, so it'll park wherever you get it.
Yeah, I would definitely agree with Steve. I would snare it to get a little bit more comfort distance from above the STJ. It's actually a nice embolization in the sense of where it is, but not perfect. We try to optimize what we're going to leave it, and I'd go back with balloon expand.
Well, let's find out what happened.
Yep.
I mean, you could also have a surgical discussion at this point, right? You've got a totally stable patient that you were on the fence to begin with, TAVR versus SAVR.
Yeah.
At this point, you also have the opportunity of maybe saying, let's take a pause,
Very
this guy's
reasonable.
totally hemodynamically
point.
stable. Talk to the family and say, hey, maybe it didn't work out the way we expected. We're putting 2 valves in this younger patient. Maybe we should just operate, take care of this right.
Yeah, and that's exactly what kind of we went through. So I think thankfully, as you pointed out, this was a favorable embolization where it was above the above the coronaries. The coronary perfusion was preserved. We had some time. I think the first thing we do most cases with under MAC and transthoracic guidance, but the first thing we did was to intubate the patient, get a TE probe down, make sure there's no aortic injury if we decide to manipulate this and snare it and pull it up higher. So that's what we did. We kind of discussed amongst our team, as well as we knew from the beginning that the patient's preference was still kind of not to have open heart surgery, and we felt like putting a second valve would be kind of without compromising the coronary flow would be an option here. So we did exactly what the panel pointed out, got femoral access, got a 25 millimeter gooseneck snare, snared the evolute, kind of just having back tension while we crossed or brought the S3 delivery system around, and we used a 23 S3, deployed it.
What factored into your decision of what platform to go with, Sapien versus Evolute for that second valve? Because for us, if we didn't have the Sapien rep there and we don't have people that can load it, then we're going to be, granted they were stable, but we'd have to wait for someone to come from, but
Yeah, so thankfully that's not an issue with our techs. Like a lot of our techs are trained and are comfortable loading, and we've had kind of similar, not similar situations, but situations where we had to switch valves for other reasons where the techs are comfortable loading the Sapien.
It looks like you only snared one tab.
Yes.
So I typically would snare both tabs.
Both. Yeah, I think what we felt that it was relatively stable and not wobbling, as we discussed before. And if the aorta was much bigger, where the valve was very unstable and wobbling, then we would definitely snare both tabs and kind of have that back tension, or even pull it much higher where it anchors and is not going to kind of slide down again.
So the question is, how far do you pull it back? I think I was looking at that also. Like you're probably saying, I would like to see that core valve back a little bit more so it's not right over the left main, but it looks like there's a little tension on the inner curve anyway with the snare. And I would guess that you probably were not wanting to damage the aorta and you felt like you had tension already. Is that right?
Yes, exactly.
Yeah. Yeah. So I think that's a great point. I would have, I think you did a great job getting this. I would have done it a little differently in that I just pull it above the STJ and then a single snare just to hold it there. The less is more, because the more you pull up, the more that outer tab is going to dig into the aortic wall. And then the second valve is a self-expanding valve, anchors the first one and takes away any possibility of it dropping. Because this, you're right, if this drops down a little into the coronary sinus, you could have a late coronary obstruction. Yeah.
But I think the choice of the second valve is a function of what your native aorta looks like and what the pathology is. If it's an aneurysmal aorta and you feel like your initial embolized valve is sufficiently above the STJ but could potentially slip down, then what Paul said makes sense. Go back with a self-expanding, pin it up. But if it's like, I felt that in this case, I would have come back with a balloon expandable as you did, because in whatever images you're showing, it looks like that first valve that's embolized is 1-to-1 sized with your ascending aorta. So I think the chance of it slipping forward is pretty minimal, although I would still optimize by snaring both tabs and pull it back a little bit more to really wedge it to the ostium of the right innominate, which is how far back I would pull it, not beyond that. But if it's a large aorta, then I think definitely self-expanding to pin it.
I think that this is a really interesting discussion, and I'm kind of neither here nor there with the comments that were made, because if you look back, I mean, we're kind of borderline, like we are not in the IFU for a 26 millimeter evolute in this case. The average sinus width was below 27, and your coronary heights weren't that robust. So now we're talking about, maybe neoskirt issues resulting in not just sinus sequestration, but like STJ sequestration at this point. And so that would be kind of what I would be thinking about with regards to another tall frame valve, although my general practice in these types of circumstances would be, like Paul said, to go in with another evolute. I think we have to be cognizant of the anatomy in this case.
Yeah, no, I think completely agree that especially the SOEs were on the smaller side, as I showed on the CT scan. I think some of the other measurements from Medtronic were more favorable in terms of the SOEs, just kind of at borderline, but still within the IFU, which was, again, and with the small annulus, that was the decision to go up front with the evolute.
Do you have more? Or?
I think this is it, basically. And we are comfortable based on the TE imaging and as well as fluoroscopy that the evolute was anchored enough and was not moving in the ascending aorta, which is why we didn't snare the other tab and try to pull it up higher.
Listen, thank you so much for showing these cases. We've all had them, and your pain is everybody else's gain. So we appreciate you bringing this and showing us that.
Thank you.
Great case.
Thank you very much. Our next speaker is Dr. Sachin Goel from Houston. You're responsible for the weather.
You're going to tell interventional cardiologists how to become a magician here, turning bicuspids into tricuspids.
Well, I'll try.
Okay.
That's like being a professor at Cornell and working in Houston. That's another magic trick.
Yeah, we're magicians. Thanks, Paul, and thanks to the organizing committee. So this is an interesting topic, turning a bicuspid into tricuspid. You know, the surgeons do this sometimes, and should we do this? Why should we do this? That's what Paul wanted me to talk about. So, we all know that bicuspid aortic stenosis is the commonest congenital anomaly. 2 to 5% of the population has this. They present with AS and AR earlier in life. A lot of these patients will have aortopathy. It is the most common reason for SAVR in patients less than 70, and about 1 in 5 patients over 80 undergoing TAVR has a BAV. As we all know, there is no randomized trial of TAVR versus SAVR in bicuspid aortic valve. Very important to note. There are some trials being planned right now. So what are the implications for bicuspid aortic valve and TAVR? There are several classifications. The most widely used classification is the Sievers classification. It is important to realize that bicuspid aortic valve is a very heterogeneous anatomy. Not all bicuspids are the same. There is obviously cusp fusion, asymmetry of the orifice, heavily calcified leaflets, raphe, aortopathy, angulation may be more compared to the usual tricuspid valves. There could be aberrant coronary ostia, and the valve platforms may behave differently. There's not a lot of data on this. There are multiple unique measurements that have been proposed, and different people do this differently, right? Most people do the traditional measurements that we do for tricuspid valve, but then people have proposed different virtual raphe ring measurements, intercommissural distance measurements, and then sizing different algorithms in addition to the annular sizing, the supraannular sizing, the Casper, the Lyra, and so on and so forth. So there's a lot that's been proposed and written about bicuspid and sizing. Again, there is no randomized trial, but there is a lot of non-randomized data looking at tricuspid versus bicuspid, which honestly is a little meaningless because you get to choose your patient's anatomy. But the Notion trial, I think, was an important trial, Notion 2 trial, where concerns were raised about poor outcomes with TAVR compared to surgery in the bicuspid population. There is some data, obviously, from Raj Makar's group, the Yoon classification, which is widely used, looking at calcified raphe and calcified opposite leaflet. These were the anatomies that were found to be associated with worse outcomes with TAVR. Most recently, the same group also published data on the underexpansion and the eccentricity of the transcatheter valve. And similar to the previous methodology, patients who had both underexpansion and expansion and eccentricity of the THV in the bicuspid TAVR was associated with worse clinical outcomes. This is a typical example of a bicuspid TAVR, right? Let me, in the interest of time, just go to the case. So you can see there is a heavy chunk of calcium right there between the left and the right. This is, not quite the third category in the Yoon classification. There's a heavily calcified raphe, but not a heavily calcified leaflet. This is, again, most of these cases, if not all, we like to predilate, sort of tricuspidize them. But it is concerning when you see that left chunk of calcium move over to the left side. This is sort of interesting to look at. But you can't put a valve without doing that. Otherwise, the valve is going to be very underexpanded. And despite the
Hey, Sachin,
predilation,
just a question for you. Sorry, it's Hemal.
Yeah.
Hey, so, I mean, you're not tricuspidizing by doing that behavior, right?
We're
I mean,
not.
you're creating room on that posterior
Right.
aspect, right?
Right. No, I'm going to talk about tricuspidization, which we haven't done, but we need to think about that. This is what most of us do, right? When we do bicuspid TAVR in today's day and
Hey,
age.
Sachin, why'd you do that case?
Was that?
Why did you do that case? How
Why?
did you get that past your surgeons?
The crowd has turned, Sachin.
Yeah.
The surgeon, maybe the surgeon was out of town. I don't know. So anyway, that's the surgeon. The surgeon is not happy. So we, obviously post-dilate this, it looks pancaked in the RAO view, and then ultimately we get a good result. We high-five. This is a good result acutely. There's, gradient is gone, no PVL, but we don't have long-term outcomes on these patients, right? There is no more than 5-year follow-up on post-TAVR bicuspid. This is another one, probably more complex anatomy with a very heavily calcified raphe, heavily calcified opposite leaflet. I won't belabor the point, but again, pre-dilation, the valve looks pancaked, and you'll see, how pancaked it looks in the TEE there. This is, really pancaked. But then, we hit it with a true balloon, and on the right side, you'll see, the valve looks much less pancaked. In fact, I would say, almost circular. But again, what are the long-term outcomes of these patients? We don't really know. And, so that is why this is another example of how these valves look pancaked despite an adequate predilation. So the point is tricuspidization. Where does this term come from? The surgeons do this. They particularly do this in young patients who have severe aortic regurgitation and they want to repair the valve. They can preserve the native valve so the patient doesn't have to, go on anticoagulation or have a prosthesis. So, there's multiple reports of this tricuspidization. And we've learned from Paul's center from Minneapolis that, THV under expansion and deformation is associated with potentially poor long-term outcome by virtue of pinwheeling, leafless stress, fibrosis, halt, calcification, and eventually THV deterioration. So this is a very important concept that I think we are starting to recognize in the last few years. In the early days of TAVR, it was just, about putting in a valve, but now we are starting to realize what are the implications of the expansion, and most of the valves are underexpanded. So that's where this concept of tricuspidization or leaflet modification for bicuspid comes from. The idea is to, convert this bicuspid valve into a tri-leaflet valve by somehow cutting the raphe or cutting the leaflet to increase the expansion and reduce the eccentricity of this valve with the potential benefits of, reduction in the risk of the TAVR by way of root injury, decreasing deformation, being able to maybe put in a larger valve and, more long-term durability. So how do you do that? So this concept is not really new. The first, I think, when I was looking through this, the first case was probably done by Danny Dewey at University of Washington about 7 or 8 years ago using the basilica technique. I don't have any experience with this technique for tricuspidization. Maybe Paul and others on the panel can talk to regarding this technique. But this is one of the first reports of tricuspidization of a bicuspid valve in order to do a TAVR in a patient with bicuspid aortic stenosis. And now we have, DASI simulation and other simulation mechanisms where you can sort of see how this would look with a split, without a split. And as you see on the right side, the red image is what the valve would look without a split, and the green is more circular and obviously less eccentric after a split. So these computational simulation models are able to predict how the valve is going to expand. And of course, we have the shortcut device now, which is being used, with the increasing experience, not for this particular reason, but this is potentially a use of this device. And they've done some bench work showing that, in a bicuspid valve, splitting the leaflet or cutting that raphe leads to more circular expansion of the valve, more, greater area of the valve, and also a less degree of eccentricity, both for type 1 and type 0. Here is no split, 1 split, and 2 split. And you can see from left to right, the area increases with, the highest area achievable with 2 splits. And the eccentricity also is less as you make the split of the leaflet and postal. So this is bench work. I'm not aware of any clinical cases, being done this way, but this is sort of a novel concept that I think we need to think about if you're going to treat bicuspid patients. Of course, we need data on randomized trial data looking at TAVR versus SAVR. But if you're going to do TAVR in these patients for long-term optimization, for putting in a large valve, for reducing the risk of the procedure, I think this is something which is a new concept, and we are looks like we have a tool for this. So this is something that I think will need to be studied. So I think to conclude, bicuspid aortic valve is a very heterogeneous population. TAVR in a bicuspid is clearly a higher risk procedure. There is risk for THV deformation, which can be modified by leaflet modification. And again, we need data on this interesting aspect, bicuspid TAVR. Thank you.
Thanks. That was great. I love hearing new ways of doing things, but I always want to think of what are all the problems that can happen with new ways of doing things. And one of the things, obviously circularizing something is very beneficial because of this rapid structural deterioration and halt we know this happens when you have a very elliptical and that most extreme example you showed. But one thing I always think about in some ways, the most common bicuspid is right-left fusion. And when we put those in, we always think it's probably a little protective against left main obstruction because it cants away from the raphe, right? So if you split it now, and we also have to be cognizant too that some people with bicuspid valves have long leaflets. We don't even talk about leaflet lengths. I don't think that's always paid attention, but do you have some concern that you could raise the coronary obstruction risk now by doing some of this?
Great point. Lots of concerns. I think coronary obstruction concern, the risk of injury to the annulus is a concern. What happens with acute AI, that would be a concern. Paul has a lot of experience with basilica. Usually with basilica, we don't see a lot of AI, but here we're cutting the raphe. So what does that do to the hemodynamics? We don't know. But I think the concept is good. Whether this will come to fruition, I think remains to be seen.
It's a really fascinating concept. The problem is that the electrosurgery is not going to ever cut the calcium. So you're going to be adjacent to, but not through the part you really want to cut. And is the price you pay for making it more expandable, do you mobilize this big hunk of calcium and make that like a weapon to become a ball valve into the coronaries? With long leaflets, we have done some native basilica, not necessarily with the intention of tricuspidization, but to sort of see what happens. I think we need some data on that. We need pre and post CTs, and we need to kind of understand what's going to happen to that calcified raphe. Does that then become like a piston, or does it just move out of the way?
Completely agree.
Hey, Sachin, you mentioned at the beginning about the lack of data with bicuspids. So if you were to, which bicuspids need to be studied? Because there's a lot of different types. You showed some cases that I thought maybe should go to surgery. So and we probably do a whole lot more bicuspid than people gave credit for. So what study are you thinking about, and which ones would you like to know more about?
Yeah, so great question, Steve. Vast majority, as you know, that we treat are Sever's type 1 with, right, left, or right, non, or whatever. But I think all kinds of bicuspids need to be studied. This is a very heterogeneous population. I know there are a couple of randomized trials that are, sort of underway, or at least in the planning phases. Presumably patients, who don't have aortopathy yet, who are not clearly a surgical candidate yet, but those patients would be, I think, fair game to randomize to surgery versus TAVR. I think that would be the first step. Of course, all this stuff is for patients who are not surgical candidates, who have poor anatomy, by the Yoon classification, or, potentially are going to be very underexpanded or, deformed. But I think we need to stop looking at TAVR in tricuspid versus bicuspid, but start comparing TAVR for bicuspid versus SAVR for bicuspid. I think that is the first step. That is a big data-free zone, right?
Well, thank you very much. I appreciate this tremendously. And thanks again. And now we're going to have, this should be an interesting case. This is going to be Hemal's ultimate TAVR case.
Thank you, Paul. Thank you, CVI organizers. My first year at this meeting, and so thanks so much. This is great. Yeah, so let's get into it. Dancing, trying to advance. Which button is it? The big one, yeah, isn't it? There we go. Okay, good. Those are my disclosures. So it is a difficult case to find because TAVR's become fairly straightforward. We've been talking about all of these horrible, potentially horrible outcomes, but in general, we're not seeing stuff like that, right? So complication mitigation has been the focus of the past decade, which has led us into a more secure, stable future. And so what's come with that has been safe and predictable outcomes. Our economic outcomes have improved at our center, where our average length of stay is a day and a quarter. Our 2024 volume was 400 cases, and you know you're really taxing the hospital system, and so you got to be efficient. And I think that in general, most centers are doing stuff like this. Device modifications, the technical modifications have led to a very bright era. Vascular complication rates have gone down. Our alternative access rates have gone down as a result of the transfemoral technologies that have come out, and then pacemaker rates have been decimated by the cusp overlap technique. However, meticulous case planning and more novel, straightforward adjunctive devices are essential because there's one truth that remains here. We cannot fully, and I would underline this, comfortably overcome what nature hands us without further innovation. We can struggle through a whole bunch of stuff and make really elaborate procedures, but are those able to be democratized? Are those able to be put into small community centers? That's kind of the question. And so I'm gonna probably put just a few words in front of this and how I avoided my ultimate TAVR case of 2025, because I think that that is kind of what we want to do. We don't wanna be showcasing horrible procedures that result in kind of lessons learned. We want to avoid these things at some point. So this is a 78-year-old female, severe bioprosthetic AS, 21 millimeter Magnus Sav about 10 years ago. You could see some of her other stuff. She's got severe COPD on HOMO 2, not a surgical candidate, was referred for a TAV and SAV. And so her access is without concern. I just show these routinely just because this was part of our CT workup, CT planning. Diameters look good, not significantly calcified, just some moderate tortuosity. You can see here that the LVOT is measuring at 71.9, it's a smaller diameter. And our inner ring for this small diameter magna is not surprisingly a perimeter of 56.9. So our coronary heights are not great. So left main height is 5.6. Right coronary height's 9.1. Clearly, there is a risk of coronary obstruction in this case if we're going to move forward with TAVR. Sinus and valsalva diameters look okay for the valve that we'd be putting in. Sinus-tubular junction looks nice and capacious. And then here's our coronary angiography, and sometimes this is all you need to see in order to really understand what you're going to be dealing with on the table when you do the TAVR. You can see that the left main is pretty much abutting that stent post of the surgical frame, and same thing for the right coronary artery. And so just looking at this, you get a sense that you're going to be dealing with some really significant coronary issues by doing a TAV and SAV. And so then you go to the second kind of phase of measuring, right? So now you're going to be putting in your little virtual ring. And here for our 23 millimeter evolute that we're sizing for, we're going to be putting in a 20 millimeter circle, and that is the waist of the evolute. And so we're looking here at VTC measurements, which are often diminutive in these cases. So 2.9 for the left, 2.8 for the right. So can we proceed with TAV and SAV as is? I'm going to answer no, because you're not, right? So then the question is kind of what strategy do you prefer in this particular instance? And so no, the left main's at risk. We're going to chimney stent basilica, the left main, left coronary cusp. No, the right coronary artery's at risk. Chimney stent basilica, the right coronary artery, right coronary cusp. No, chimney stent basilica, both. No, throw a unicorn in somewhere. No, TAVR is not possible, demand surgery, which surgeons are going to laugh at you. And then, what we didn't talk about today was I want to get out of here at some point to eat dinner with my kids. How do we make this happen? And so all of these procedures where we're doing leaflet modification, I mean, they can go hairy very quickly. Very straightforward leaflet modification procedures exist, but they're largely unpredictable. And so We need devices, we need therapeutics that are designed for this purpose that are definitely more straightforward. And so to continue with the theme of the Basilica transitioning to unicorn, people have shown this, this virtual imager, this mock image so many times. This movie plays at every single course that I've ever been to in the last 8 years, and it's deservedly so, because this is just a gigantic innovation in the field. I mean, it's amazing what we're able to treat now because of this technique that we weren't able to treat safely in the past. And so with the democratization of this has come unicorn, which is basically just that one puncture through the leaflet and then basically using a balloon inflation to then house a valve in a leaflet, tear that while you're deploying the valve. This can be intense, okay? And so really, if you're gonna be doing 2 leaflets, and if you're gonna be using Basilica, then you're using 2 large bore sheaths, and that comes with some vascular issues, especially in some of these patients with smaller anatomies that really don't have that vascular access. And it's gonna require a lot of off-the-shelf stuff. Now, I'm not gonna talk about Telltale in this particular talk, but I think that's something that we can bring up on the panel discussion with the pachyderm catheters, putting it all in one box, and does that democratize the procedure further? Maybe Unicorn simplifies this a little. This is a recent case that we reported in JACC case reports, where we basically did a modified technique where we Basilica one leaflet, Unicorn the other, deploy self-expanding valve. It still requires a ton of equipment and a ton of steps. And so this is not something that can be routinely done at most centers. And so what Sachin touched on is a device that we've come to know and use very well. We've done about 14 cases with this device at this point. Most of them were in the IDE study. We have now used the commercial device in a handful of cases, and I'll talk about that. But it's really all through the single 16 French access that you need. And oftentimes, obviously, we're doing a lot of self-expanding valves. And so that's a 14 French equivalent catheter. We'll put in an 18 French sheath in order for those procedures to happen. And then we can just do everything through that large bore TAVR access. And so Sachin kind of showed the splitting element, and this is kind of what it looks like just on fluoro. You're unsheathing this device, you're rotating, you're basically centering yourself on a leaflet, you're activating a splitter, and then in the current generation of shortcut, you're basically pulling and pushing on the wire simultaneously in order to lacerate. With Shortcut Pro, which is their next generation device, it is basically a slide rule. So you're basically going to have a very controlled blade that is going to be able to cut the leaflet in whatever trajectory you decide to do. This is the case that I was showing, and so this is the split of the left coronary cusp. We activate the splitting element. We have very good TE visualization of where we're putting the device, and then we have very good TE visualization of the cut, obviously. The right coronary cusp is very easy. Now, these views can be sometimes very steep. For the left side view, it's usually the easiest to obtain. For the right, the front view is usually the easiest to obtain, the orthogonal views. And so it's quick to go to those if you've got good TE imaging. And here we just basically rotate the delivery catheter, come right back down, and split the right coronary cusp. And then we have the quintucuspid aortic valve that you see there, with you could see splits that are centered right around where those coronary ostia are. Then our practice usually in these cases is to pre-fracture. So we picked a 22 millimeter true balloon to respect the LVOT, and that's kind of the result of the pre-fracture. And then we do post-overlap, obviously, when we're deploying the valve. And just to scroll through that, you don't need to see this. It's going to be very quick. We typically rapid pace in our valve deployments, and that also is a top-down deployment. And then this is our result, and you can see that the coronaries fill very nicely. And this is the result on echo. And then, of course, superior hemodynamics is supraannular platform. So some pertinent statistics for that last point that I was making about being home with your kids for dinner. Sheath in at 9:50, sheath out at 10:37. Shortcut device time was 8 minutes for a dual leaflet split. And so this is the kind of the transformational nature of this technology. This is a shortcut IDE study. I'm not going to go over the data in great detail, but for people who are unfamiliar with the literature that led to commercialization, I encourage you to read this. It is now commercial with some practical issues. On-label use only, so what Sachin was talking about is research fodder. They do not allow that case to happen as far as tricuspidization of leaflets. The pricing, $15,000 per shortcut catheter. You sell them in packs of 4. Okay, so we'll see how that changes as they petition for a new tech add-on payment, as they maybe get their own DRG code over time. A lot of that is going to require more robust post-market data, and it is a very limited rollout right now. They have a small sales force, clinical team, about 30 sites they estimate will be launched by the end of 2025. So some take-home points. We obviously need innovation, especially in these higher risk, challenging cases that we do. Shortcut does allow for single or double leaflets with short procedural times, utilizing your main TAVR access only. And with the expansion of TAVR in the young populations, as multiple valve interventions may be required, there is a need for this type of dedicated leaflet splitting tool for several indications. Sachin talked about tricuspidization of bicuspid valves. I think that is definitely fodder for study, but then even beyond that, so high-risk coronary anatomies that are kind of at risk for the native valve as far as TAVR is concerned. Are you going to be able to, kind of avoid obstruction? And then facilitation of lifetime management, and can that have some sort of role with regards to simulation? That's all I have. Thanks so much.
So,
Hemal, fantastic talk, as always. You really highlighted a couple things. One is that leaflet modification in its current form needs to evolve. Shortcut is very exciting. It's the first dedicated commercially approved device to do this. And then it comes out at this prohibitive cost. So it makes sense. If you're going to do 4 a year, it makes sense. If you're going to do 4 a month, I'm not sure this is going to be the answer.
Agreed, completely. And so we've reserved this for dual leaflet splits. And in the commercialization era of this, the handful of cases that we've done have all been dual leaflet splits. In the trial, 37% of the patients that got shortcut got dual leaflet splits. So I would estimate that it's going to be a higher rate of dual splits in commercial use.
That's a great strategy. There was a comment?
what price do you put on having dinner with your kids? Because $15,000 at 4 pops, it's not a bad price, assuming you have good kids and you love your kids.
Yeah.
Now, for those of us who don't have kids, which I do, but if someone didn't,
you have people that you enjoy having dinner with.
Having dinner with your wife.
Yeah, there you go.
Yeah, the real question, leaflet, why would anyone, surgeons don't leave leaflets behind. So if we had a way to get leaflets out of the patient, both native and redo TAVR, redo SAVR, why wouldn't you? If you can do it safely, if you can do it efficiently, you're setting yourself up for, so I think this is very exciting. Thank you for showing that case. It's a great case. It shows not only a very complex case, it can be treated very quickly and very efficiently. We just need to get the tools in the hands of people and at a price that, frankly, I don't understand the pricing strategy of this device.
Well, yeah, it's all kind of like economic gamesmanship, right? This is what they need to come out with. And we see those with drug-coated balloons now, too. Yep. They're coming out with these high inflated prices in order to make the market kind of adjust, maybe get a new DRG coding for use of their particular device. Maybe TAV and TAV needs its own particular DRG just because of what we're throwing into those cases. And maybe that's the bigger argument here.
I don't love this device for TAV and TAV because I don't know if it gets enough of a dramatic split to allow for perfusion.
We've done a couple, and I agree with you. I think that, some of the splitting that we've done has been a little, I would say, not in line with where we expected the cut to go.
So, Alan, if you put your crystal ball in, if Paul invites you back in 5 years from now, what leaflets are going to be split and with what devices? Are we going to do natives? Are we going to do bicuspids? Are we going to do only surgical valves? Are we going to do all the TAVR valves that we do? Are we going to do everything all the time, and what device we're going to use?
I think we're going to use devices that allow us to circularize and expand the most and minimize the risk of obstruction. If you have a high risk of coronary obstruction or even an intermediate risk coronary obstruction, as the embolic rates decrease or as we use another adjunct procedure to minimize the risk of embolization when you do leaflet modification, you're probably going to end up doing both in order to expand your new prosthetic the most.
I don't think there's going to be a winner, as most things in this field, right? I think that shortcut is definitely going to have a role for these dual split cases. And to Paul's point, I don't know if it's going to be the answer for TAV and TAV, but TAV and SAV, ostensibly, this is going to be the answer for dual splits. I think that there is a lot of advantage in packing all of the basilica apparatus into one box. What's the price point for that going to be? Is that something that's going to be worth considering? Is the stuff that we're doing off the shelf like not as good as putting it into one box? This is another question that we need to answer. And then what cases are going to need complete resection of leaflet anatomy? And what are those techniques and tools going to look like? And then most of all, with all of that, how are patients going to react to these procedures? If we are doing shortcut or basilica, they're going to react one way. If we're doing unicorn, they react a little bit more profoundly. If we're now resecting leaflets, I mean, we're opening us up for a little bit more of tense moment in these procedures.
I would just also say we're so focused on the devices, but I think we also need better predictive models to actually help us figure out what we need to do and maybe what we don't need to do.
Yeah.
So we know that we often protect coronaries, and then we find out we don't need to, and we rarely deploy the stents. As Hemal knows, hopefully the Restore registry will help us. I did a Restore case yesterday right before getting on the plane, which is a terrible thing to do, these types of cases, and then leave town. But I got 10 different opinions from all leading experts, and it was split both, split neither, it's going to help, it's not going to help, protect both, don't, all these different opinions. So it's clear that we really don't know, and I think we need better predictive modeling to help us. Maybe DASI has obviously potential. I don't think it's quite there yet, but
More
that'd
to
be
follow.
helpful.
We're going to let our Paul, we're going to give you the last question. Okay.
This is great. I'd love to hear the insight on basilica, Paul, but as far as shortcut is concerned, it was 100% utilization in the IDE. And that stroke rate was obviously very low, but as time has moved on, as the commercialization has gone on, the sentinel use has become a little bit patchier over time. I think it's definitely worth more study and more consistency with regards to utilization of cerebral embolic protection. Paul, what do you think about basilica with stroke?
So we had registry data with 250 patients in the registry, non-randomized, but about half of them got sentinel, about half didn't. We saw no difference in stroke rates. So it doesn't appear to offer any clinical benefit in this setting.
And that may be more a virtue of the device that we're using for the cerebral embolic protection than anything else.
Well, Hemal, great job. Thank you. I think Paul has an announcement.
Thank you. Thanks, everyone. So it was a great session this morning.